So hello and welcome to MDJF lectures. From now we'll be talking about the lower limb anatomy specific to the MRCS Part A. So first of all, we have a 78-year-old man who has intermittent claudication. His ankle brachial plexus index is measured. To do this, dorsalis pedis artery is identified. So they have given you different statements and you're supposed to identify that which of the statement is not correct with reference to the dorsalis pedis artery. We know that it originating from the peroneal artery will be a false statement because we know that the dorsalis pedis artery originates from the anterior tibial artery. Now, as you could appreciate over here, before the ankle, the anterior tibial artery is present in the anterior compartment, and as it crosses the ankle joint, it is going to become the dorsalis pedis artery. Now, the reference to the dorsalis pedis artery, it is having extensor hallucis longus as a medial relationship and extensor digitorum longus as the lateral relationship. Now, it lies in the first web space between the first and second metatarsals. Now, as it comes over here, it is going to dip down between the first dorsal anterosciatus two heads, and it is going to communicate with the lateral plantar artery to form the plantar arch in the foot. So which nerve passes through the greater sciatic foramen and it also innervates the perineum. So we have the pudendal nerve. Basically, pudendal nerve is having three branches, that is the rectal, perineal, dorsal nerve of penis and clitoris or clitoris. All these passes through the greater sciatic foramen and pudendal nerve innervates the perineum. It passes between the piriformis and coccygeus, being medial to the sciatic nerve. So identification and understanding of this area of the lower limb is very important. So here the most important nerve is the sciatic nerve, which is one of the thickest and longest nerve. Now it passes beneath the piriformis. It has different variations. It can pass through the substance or above, but mostly it passes inferior to the piriformis muscle. Now here, first of all, we're going to have the superior gemelli, then we will be having the obturator internus, inferior gemelli and quadratus femoris. In addition, there will be this pudendal nerve and the posterior cutaneous nerve of thigh. Now, this area which is in which the piriformis muscle is present is going to encompass the greater sciatic foramen, and through this is going to the passage of the pudendal nerve. Now, pudendal nerve, there is also one point that it is a nerve which passes not only through the greater sciatic foramen, but it also passes through the lesser sciatic foramen. So, it has two things which are very important. So, as you could appreciate that here we have the gluteus maximus, gluteus minimus. This is the piriformis, and the structure which are going to be passing superiorly and inferior to piriformis are going to be the constituents of the greater sciatic foramen. So the structures which are going to be the part of the greater sciatic foramen is going to be the sciatic nerve, superior and inferior gluteal nerves, internal pudendal nerve. Among the vessels, we have the superior and inferior gluteal artery and vein and internal pudendal artery and vein. Now, out of these, the sciatic nerve is going to be the main innervation of the posterior aspect of the thigh as well as the leg. The superior gluteal nerve is going to innervate the gluteus medius and minimus, and inferior gluteal nerve is going to innervate the gluteus maximus. And we have discussed previously that the internal pudendal is going to divide into three branches, that is the rectal, pudendal, and the dorsal nerve to penis in men and clitoris in females. And out of these, the perineal nerve is going to supply the perineum. So the structures passing through the lesser sciatic foramen include tendon of the obturator internus and the nerve to the obturator internus, and the pudendal nerve and the internal pudendal artery and vein. So these two structures are going to be the part of the greater as well as the lesser sciatic foramen. So 53-year-old man presents with carcinoma of the transverse colon. Which structure should be ligated close to their origin to maximize clearance of the tumor? So we know that this area of the colon, that is the transverse colon, which starts from the hepatic flexure towards the splenic flexure, is supplied by the middle colep artery, and middle colep artery needs to be ligated in order to maximize management of the cancer. Now, this middle colic artery is branched from the superior mesenteric artery, which is one of the anterior branches which are directly originating from the abdominal aorta. For the right-sided colon, we have the right colic artery, and for the cecum and the appendix, we have the iliocolic artery, which is going to supply the terminal part of the ileum, the cecum, and going to give multiple branches, out of which one branch is going to supply the appendix as well. On the left side, the descending colon is going to be supplied by the left colic artery, which is going to be given by the inferior mesenteric artery. So, which structure is not contained within the rectus sheath? So, that will be the internal iliac artery. Now, internal iliac artery is one of the divisions of the common iliac arteries, which is given off in the pelvis area. Now, we need to know that what on the other end is contained by the rectus sheath. It contains the superior epigastric artery and vein and inferior epigastric artery and vein. So basically, the rectus sheath is formed by the aponeurosis from the different muscles, and we'll have a discussion for this in the next slide. So as you could appreciate that there are two very important concepts related to the rectus sheath, that what are the contents and what are the different layers of muscles which are forming it at different locations. So this arcuate line is the landmark for this differentiation. Above this arcuate line, the rectus sheath is forming two layers, that is the anterior layer and a posterior layer. Now, this anterior layer is contributed by the external oblique and the anterior lamina of the internal oblique. Now, the posterior lamina of the internal oblique along with the transversus abdominis is going to contribute to the posterior layer. But below the arcuate line, all the three muscles, external oblique, internal oblique, and transversus abdominis, are going to contribute anteriorly. And on the posterior aspect, the rectus sheath is going to be deficient, and that area will be below the arcuate line. Now, there is another thing, that superior epigastric artery vein and inferior epigastric artery and vein are the structures which are present within the substance of the rectus sheath. Now, inferior epigastric artery is a branch of the external iliac artery, whereas the superior epigastric artery is branched from the internal thoracic artery. This internal thoracic artery is a branch from the subclavian artery. A 73-year-old lady presents with right iliac fossa pain. Cecal diameter is measured, and they're asking you that which cecal diameter is going to be pathological. That is this 10 centimeter. Now, with reference to different locations of the large gut, we have specific numbers which we need to know that they are going to be pathological. So for cecum, we need to know the maximum limit, and that is the 10. That is going to be for cecum. For ascending colon, it is 7 centimeter. For transverse, it is 6.5. For descending and sigmoid colon, it is around 7, or you could appreciate 6.8. And for rectum, and for the rectosigmoid junction, we have the value of 7.5 centimeter. That is going to represent the pathology. The foramen marking the termination of the adductor canal is located in. So it is going to be the adductor magnus muscle. Now, here you could appreciate that we have two very important structures, that is the femoral triangle and the adductor canal. Now, the femoral triangle is bounded by the sartorius and the adductor longus. Sartorius on the lateral side, adductor longus on the medial, and superiorly by the inguinal ligament. Whereas the adductor canal is bounded superiorly or anteromedially by the sartorius, laterally by the vastus medialis. So, posteriorly, it is bounded in two parts. In the upper part by the adductor longus, and in the lower part by the adductor magnus. This area, which is going to represent the termination of the adductor canal, is present in the adductor magnus muscle. Now, the structures which are going to enter the adductor canal is going to reach or enter the popliteal fossa, and the components include the femoral artery, femoral vein, saphenous nerve, and nerve to vastus medialis. Now, femoral nerve is not a component. Instead, this saphenous nerve, which is a cutaneous branch of the femoral nerve, is going to be part of the adductor canal. So, which nerve supplies the first web space of the foot? That is going to be the deep peroneal nerve. Now, we know that the common peroneal nerve is going to supply the branch into the deep peroneal nerve and the superficial peroneal nerve. Now, out of these, the deep peroneal nerve is going to supply sensory component as the first web space, whereas the rest of the dorsum is supplied by the superficial peroneal nerve. A superficial peroneal nerve is going to supply as a motor component, that is the lateral compartment, that is going to include the peroneus longus and brevis, and the deep peroneal nerve is going to supply the anterior compartment, which is going to include the tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. Now, with reference to other innervation, the lateral component of the anterior surface of the foot is supplied by the sural nerve, whereas the medial component is supplied by the saphenous nerve, which is also supplying the anterior and posterior aspects of the medial aspect of the leg as well. Saphenous nerve is one of the branches from the femoral nerve. Now, on the posterior aspect, as you could appreciate in this green color, this is by the sural nerve. Now, this sural nerve is going to supply the lateral component on the posterior aspect of the leg, and it is also going to supply the lateral border of the foot as well. Now, on the sole of the foot, you could appreciate different nerves. This calcaneal area or the heel area is supplied by the tibial nerve. The medial border is supplied inferiorly on the sole by the saphenous, and lateral border by the sural nerve. And in the sole, the medial 2/3 of the sole and 3.5 digits are supplied by the medial plantar nerve, whereas 1/3 of the sole laterally and lateral 1.5 digits are being supplied by the lateral plantar nerve. Now, this lateral plantar nerve and the medial plantar nerve are branches from the tibial nerve, which is again a direct branch from the saphenous nerve. So, which ligament contains the artery supplying the head of femur in children? It is the ligamentum teres. Now, as you could appreciate, this is the femoral head. Here we have the acetabulum, and in the boundary we have the acetabular labrum. Now, the connection of this acetabulum to the femoral head is this ligament of the head of femur known as the ligamentum teres, and it contains the vessel which is going to supply the femoral head in children especially. So, during block dissection of the groin, the sartorius muscle is identified. So, what is the nerve supply of this muscle? So, we know that the anterior compartment in which the sartorius is present is supplied by the femoral nerve. Now, they are further divided or given you an extension that out of femoral nerve, which division is going to supply the femoral sartorius muscle? That is going to be the anterior division. So, the femoral nerve primarily divides into an anterior division and a posterior division. Now, anterior division has sartorius as the motor innervation, whereas it is going to supply the medial cutaneous nerve of thigh and the intermediate cutaneous nerve of thigh as the sensory branches. Whereas from the posterior division, rectus femoris, vastus medialis, intermediaris and lateralis are going to be the motor innervation, and the saphenous nerve will be from the posterior division, and saphenous nerve is one of the cutaneous branches of the femoral nerve. So, 25-year-old man, he got stabbed in the groin. The area within the femoral triangle is being explored. Which structure is going to be responsible for the lateral wall of the femoral triangle? And that is the sartorius. So, the medial border of the sartorius is going to form the lateral boundary, and the medial border of the adductor longest muscle is going to form the medial boundary. Superior boundary will be by the inguinal ligament. So this is going to be our triangle. Now within this triangle, we have the floor being formed by the pectineus and iliopsoas muscle. Now lymphatics, femoral vein, femoral artery, and femoral nerve, and in some texts, the lateral cutaneous nerve of the thigh is the component or the contents of the femoral triangle. Do not get confused that in the femoral canal, these structures are going to be present. That is the lymphatics, vein, and the artery. Femoral nerve is not a component of the femoral canal, but it is one of the component of the femoral triangle. A 23-year-old man has severe growing pain several weeks after a difficult inguinal hernia repair. Which nerve is most likely to be involved? So, whenever a patient is experiencing pain after hernia repair, it is going to be the ilioinguinal nerve, which is likely to get entrapped when you're using a mesh and eventually results into a neuroma formation. So this diagram very beautifully illustrates this concept that the ilioinguinal nerve can get entrapped while placement of the mesh is being done during the hernia repair. 19-year-old man playing rugby had severe pain in the posterior lateral aspect of the right thigh. Which muscle group is most likely to be injured? That is going to be the long head of the bicep femoris muscle. So we need to appreciate that in the posterior aspect of the thigh, which muscles are present. And these muscles are the hamstring group of muscles. These are semitendinosus, semimembranosus, and the bicep femoris. Bicep femoris has two heads, a long head and a short head. Now, out of these, the semitendinosus and semimembranosus are present on the medial aspect posteriorly, and bicep femoris is present on the lateral aspect posteriorly. Now, semimembranosus and semitendinosus are both supplied by the tibial nerve, whereas the long head of the bicep femoris is also supplied by the tibial nerve. However, the short head is supplied by the common peroneal nerve. Now, sciatic nerve is going to divide into two branches, that is the tibial nerve and the common peroneal nerve, and this is their distribution. Popliteal fossa, the common peroneal nerve is going to further divide into the deep peroneal nerve and the superficial peroneal nerve, which we have discussed previously in the foot region, and they have their specific motor and sensory innervation. A 23-year-old man, he got stabbed in the posterior aspect of the right leg. Knife passes into the popliteal fossa and he sustains injury to the tibial nerve. Which muscle is least likely to be compromised? And that is going to be the peroneus tertius. We have discussed previously, peroneus tertius is one of the components or muscles of the anterior compartment of the leg, and anterior compartment is supplied by the deep peroneal nerve, which is a branch on the common peroneal nerve. Whereas tibial nerve, let's talk about that. So sciatic nerve is going to divide into tibial and common peroneal, out of which the tibial is going to supply the popliteus, plantaris, gastrocnemius, soleus. Now gastrocnemius and soleus along with plantaris are the superficial posterior muscles of the leg, whereas the tib posterior, flexor hallucis longus and flexor digitorum longus are going to be the deep component of the muscles of the leg. They are also supplied by the tibial nerve. Now, as it passes behind the medial malleolus, the tibial nerve divides into the medial and the lateral plantar nerve. Now, this medial component, we have discussed previously, is detailed, is supplied by the medial plantar nerve, and this one is supplied by the lateral plantar nerve, and this area on the heel is directly being supplied by the tibial nerve. As you could appreciate from here, that here it is going to divide into the medial and the lateral plantar nerve, and it is going to have its different innervation to the foot muscles, which is less likely to be tested for the MRCS Part A exam. So which structure is at risk of direct injury following a fracture dislocation of the femoral condyles? We know that on the posterior aspect of the femoral condyles, we have the popliteal artery, and it is one of the most likely structure to get injured in the fracture dislocation of the femoral condyles or even the posterior knee dislocation. Head of the gastrocnemius will contract to pull the fracture segment posteriorly, and popliteal artery lie against the bone and can get damaged or compressed. The following are true for the femoral nerve except it supplies the adductor longus. No, adductor longus is one of the muscles of the medial most compartment, and this medial compartment is supplied by the obturator nerve. So femoral nerve, you discussed previously, is going to supply the pectineus, iliopsoas, quadratus femoris, and sartorius muscle, and it is going to give various sensory branches as well. Whereas this adductor longus, adductor brevis, adductor magnus, and gracilis, which are being component of the medialmost compartment or the adductor compartment, are being supplied by the obturator nerve. So operation for the varicose vein is being done and mobilization of the long saphenous vein is being carried out. There is point of entry to the femoral vein and artery is injured and bleeding is encountered. So what is going to be the vessel that got damaged? So as you could appreciate from this diagram that this is the femoral vein, and in this there is a contribution from the great saphenous vein. Now in this area there is passage of the external pudendal artery, that is the deep external pudendal artery to be more precise, and it is running over here in this area. Now this is at a higher risk of being damaged during the operation when there is mobilization of the great saphenous vein during the varicose vein surgery. Now there are three very important tributaries of the great saphenous vein which needs to be revised. That is the superficial circumflex iliac, the superficial epigastric vein, and the superficial external pudendal vein. Now, the deep external pudendal artery is a branch of the superficial femoral artery, and it runs medially under the long saphenous vein near its point of union with the femoral vein. Now, the important thing is that neither vessel is important, and if there is bleeding, they can very easily be ligated. A 56-year-old lady who had metastatic breast cancer develops osteolytic deposits in the proximal femur. One morning, severe groin pain and lesser trochanter has been observed. So which muscle is going to be the culprit? So we know that the insertion of the psoas major is on the lesser trochanter area, and if the female was having a osteoporotic bone because of the mets from the breast tumor, so it is going to result into the avulsion fracture, which is one of the types of the pathological fractures, and it is going to be because of the psoas major muscle as it inserts on the lesser trochanter and contracts when raising the trunk from the supine position, and it results into osteolytic lesions being present in the lesser trochanter. A 67-year-old man, transurethral resection of the bladder tumor is being carried out, and during the diathermy, there is experience of the sudden movement of the patient's thigh to the that it starts to twitch, or there is a kick-like thing from the patient's end while being sedated. So stimulation of which nerve is going to result into this pathological sign or clinical picture? That is going to be the obturator nerve. Obturator nerve is most closely related to the bladder, and during the use of diathermy, it is likely to get stimulated, and as a result the patient is going to experience twitch, or there is going to be a kick-like movement of the patient's leg, which is not contained within the deep posterior compartment of the lower limb. So we know that sural nerve is not the component of the deep compartment as it is present in the posterior compartment superficially. Now, sural nerve is superficially sided and therefore it is not present in the deep compartment. Let's revise some anatomy. So, in the popliteal fossa, on the medial side we have the semimembranosus and semitendinosus. On the lateral we have the bicep femoris, And here we have the tibial nerve and the common peroneal nerve. Now there is contribution from both these nerves to form the sural nerve, and the sural nerve is going to run over the gastrocnemius muscle, and it is going to be present in the superficial aspect of the posterior aspect of the leg. So which muscle does not insert on the medial or the superior medial aspect of the greater trochanter? It is going to be the quadratus femoris muscle. So the muscles which are attached on the greater trochanter are given by these colors. We have the piriformis, the superior and inferior gemelli, the obturator internus. However, the quadratus femoris muscle is inserted on the quadrate tubercle, which is present on the intertrochanteric crust on the posterior aspect of the femur. Now, piriformis, obturator internus, the gemelli and obturator externus with the mnemonic of POVO are going to be inserted on the greater trochanter. And we have discussed in the previous slide that the lesser trochanter has insertion from the psoas major muscle. So you need to know the origin and insertion of major muscles, which can be tested on the exam. A 30-year-old man presents with back pain and the surgeon is going to test his ankle reflex. So what is going to be the nerve root value for the ankle reflex? We know that it's going to be the S1, S2. For the Achilles or the ankle reflex, we have S1, S2. For the patella or the knee reflex, we have L3, L4. For the biceps, we have the C5 and C6. And for the triceps, we have C7 and C8.